questions in the chat session, and we will try to get them to as soon as possible. Having said that, no further ado, I will hand over to the care team at the care hospitals so they can start the webinar. Maninder and Inderjeet, back to you guys.
Use your mic name here. Use mic. कौन से?
Inderjeet, you're good to go. Please go ahead.
Good morning, everyone. A warm welcome to you all from Care Hospital, Sever Care Group, Hyderabad, India. Hope I'm audible to you, all of you.
Yes, sir, we can hear you.
Yeah. Thank you very much for gathering at your place and listening to us about the kidney disease. And all of us are struggling with the kidney disease and kidney disease management. It's a global pandemic, basically, everywhere in India, in African countries, in American countries, North America, South America, everywhere we have this kidney disease burden. So it's a burden not only to the society, to the nation, and also to the family. Families also suffer because of kidney disease, because of the enormous socio-economic burden on the family. So this is where we work. This is Care Hospitals Hyderabad. It's a state-of-art, multi-speciality, multi-centric, multi-organ hospital. Multi-organ transplant are being done in this hospital with state-of-art technology and center of excellence for liver, kidney, heart transplants. So this is the picture of the hospitals in Hyderabad, India. So just a brief, I'll be briefly covering about management of kidney disease and kidney transplantation. But the main transplantation procedure and all will be dealt by our chief lead transplant surgeon, Dr. Parsad Raju will be covering on the renal transplantation aspect. I'll be briefly covering on the kidney failure management aspects. So today we'll briefly learn about functions of kidneys, CKD, a silent killer, signs and symptoms, progression, what causes kidney disease, brief management, and management of end-stage kidney disease, including renal transplantation. We'll just go through these. This is the overview of today's discussion. So as you all know, kidneys are two in number. They are bean shaped in structure, which one is on the right side, one is on the left side. Usually they measure about 10 to 12 centimeters in length, 5 to 7 centimeters in width, and 2 to 3 centimeters in thickness. Gross weight will be about 150 grams in males, 135 grams in females. So it has got a cortex and a medulla. So this is how briefly the picture of kidneys look like. So right kidney, left kidney. This red one is the aorta, blue one is the inferior vena cava vein. This is artery, and this is the urinary bladder. This is the urine pipes which carry urine from kidneys to the bladder, and from the bladder urine is passed through the urethra. So this is a brief structure how the kidneys look like inside our body. So this is, we have about 1 million nephrons will be there in each kidney. So 1 million nephrons. So each nephron is the functional unit. So the kidney functions with this nephron. And if you have a healthy kidney, we call it as 100%. What function of kidneys would be around 100%. So this is how the inside the functional unit looks like. These tubules carry the urine, and the various concentrating mechanisms happen in these tubules. This is how the inside of the kidney, that is functional unit, looks like. And coming to the important functions of the kidneys. Important functions of the kidneys. What does the kidney do? They regulate the blood pressure. Most of us think that heart does the job of maintaining blood pressure. It's actually the kidneys which maintain the blood pressure, regulation of blood pressure. If somebody's blood pressure is very high, like say 200 or 180, 160, they should be careful. They should look at whether their kidneys are at stake or whether there is any problem with their kidneys. So most important is regulation of blood pressure. Then regulation of bone mineral metabolism. So somebody's calcium, phosphorus, magnesium, vitamin D, everything is being regulated by the kidneys only. So see, there is one entity called as CKD, MBD, bone mineral disease also is there with chronic kidney disease. So this is also is done by the kidneys. And the body's pH is also maintained, acid base, as acidic pH, base pH. So neutral pH, 7.4 pH is being maintained by the kidneys. The other organs which maintain the pH is the lungs also. So usually if there is a kidney disease or metabolic acidosis ensues because of kidney disease, so then the only option left is dialysis or kidney transplantation. So pH also is maintained by the kidneys. Excretion of waste products, so removing the waste products from the body also is maintained by the kidney disease. And also red blood cell production. That means usually kidneys produce the hemoglobin. Most of us think that hemoglobin is maintained by the bone marrow and things like that. So actually, the kidneys produce a protein called as erythropoietin, which this erythropoietin maintains the blood in our body. So very important organ in our body, kidneys, which regulate blood pressure, blood, maintaining the pH, excretion of waste products, regulation of bones. So very vital organ the kidneys are. So once there is blood flow into the kidneys through that red color thing which you are seeing, radiate artery, the blood will come into that artery and goes into that filtering unit, that is the glomerulus. So what happens is there are three processes that takes place. One is glomerular filtration. So this glomerulus which you see, the one which is denoted there in that red circle, that is filtration will happen there. Then the filtrate which comes into the tubule, the waste ones will go out and the new good ones are absorbed. The tubular reabsorption takes place and some tubular secretion also takes place, and then which happens into the tubule, and then there is formation of urine. Urine is excreted via the collection system into the ureters, into the bladder. So that's how these three processes are there for the formation of urine. So important hormones, if you see, that are regulated, just now we discussed for maintaining blood, erythropoietin; for maintaining blood pressure, renin is there; for maintaining bones, calcitriol is there. So these are the three important hormones secreted by the kidneys. So if you look at definition of CKD, what is kidney disease? So most of us might think that, okay, we don't have a kidney disease. Some people doesn't do screening for kidney disease. So why it is very important is that kidney disease is defined as abnormalities of kidney structure or function present for more than 3 months with an implication for health issues. So then we call it as CKD. So if there is a decreased GFR, that is less than 60 mils per minute without any issues for more than 3 months, also qualify for CKD. If they have abnormalities like protein loss, urinary sediment like RBCs in the urine, different electrolyte abnormalities like increase in the sodium or decrease in the sodium or increase in the potassium, phosphorus, any abnormalities in the electrolytes also qualify for CKD. Any abnormalities by histology, that any biopsy was done, then any structural abnormalities like horseshoe kidney, single kidney, or any ureteric anomalies, duplex moiety, two ureters, all these qualify for a structural abnormality. And if there is any history of kidney transplantation, also will qualify for CKD. So when the kidney function is less than 25%, it poses serious health problem. And when the kidney function drops to less than 15%, the person will need some form of renal replacement therapy like dialysis or transplantation. The driving point here is most of the times the kidney disease is not known. It is a silent disease. So till the kidney functions comes to below 25 or 10, the person will not know that he has a kidney problem. So that's how one needs to go for screening methodologies. Then only we will come to know that somebody has a CKD issue. So sometimes you people might have heard that there's something called as acute kidney injury, and we talked about chronic kidney disease. There's something called as acute renal failure also can be there. What is acute renal failure and what is chronic renal failure? Means if prior known creatinine increase is there, then they call it that is more than 3 months. If you know that the creatinine is high, then we call it as chronic kidney disease. Sonogram showing ultrasound showing abnormalities in the kidneys, again chronic renal failure. Sonogram showing enlarged or normal kidneys, it can be there in both. Oliguria, if it is there, can be there in both. Increase in creatinine and urea, so it can be there in both. No anemia in acute renal failure. Anemia is part in chronic renal failure. Severe anemia can be seen in chronic renal failure. Chronic symptoms can like fatigue, pruritus, nocturia, hypertension. All these are more common features of chronic kidney disease. So stages, what are the stages? So sometimes people might ask what kind of a CKD I have, what stage of CKD I have. If it is CKD means do I really go for dialysis or transplantation? If I have CKD, should I immediately go for kidney transplantation? No, it's not true because CKD is classified by stages according to the GFR. If you are CKD stage 1 means more than 90 GFR. CKD stage 2 is 60 to 89. CKD stage 3 is 59, 30 to 59 is CKD stage 3. CKD stage 4 is 15 to 29, and less than 15 means complete kidney failure. When somebody's GFR is less than 15, they need to go for some sort of a renal replacement therapy, either dialysis or transplantation. So up to CKD stage 5, one need to be meticulously following up with the nephrologist and take treatment for not to allow the kidney disease to progress further. So this is the same, but if somebody has proteinuria also, because proteinuria again has a bearing on the progression of kidney disease. Somebody has high proteinuria, their kidney disease will progress faster. So what are the risk factors for CKD? Who all should go for risk assessment? So somebody who has diabetes, hypertension, cardiovascular disease, heart failure, peripheral vascular disease, cerebrovascular disease, all these are risk factors for CKD. Somebody has kidney disease per se, like stones, prostate, or renal tract disease. They also have to be very careful that they can progress to CKD. Multi-system diseases like lupus, and various other autoimmune disorders are there. Family history of CKD or hereditary disease or like cystic diseases like ADPKD also are the risk factors for CKD. And sometimes if they have proteinuria and hematuria, which was detected on a routine basis, they can always progress to kidney disease. So there are various susceptible risk factors, like factors that increase susceptibility, somebody smoking, alcohol. So these are all the susceptibility factors. Initiation factors, factors that directly initiate kidney damage, like something like somebody is using painkillers or some sort of antibiotics, aminoglycoside, they initiate kidney damage immediately. Progression factors, somebody has a kidney disease like diabetic kidney disease, that person is smoking, alcohol, taking high salt diet, taking high non-vegetarian diet, they worsen the progression of kidney disease. End-stage kidney disease, factors that increase morbidity and mortality in kidney failure, especially cardiovascular disease or cerebrovascular disease. These are the very common factors which increase the mortality or morbidity in kidney failure patients. So what are the common causes of CKD? If you look at the common causes, major causes are chronic tubular interstitial nephropathies, glomulopathies, various glomerular diseases associated with systemic disease like say SLE or diabetic, then hereditary nephropathies, hypertension, obstructive uropathy, renal vascular disease, ischemic renal disease or vasculopathy of renal arteries and vein. So all these are the common causes of kidney disease. So how do we evaluate? Initial evaluation should include a complete blood count, urine analysis, urine protein creatinine ratio, and a serum creatinine with estimated GFR, blood urea nitrogen, electrolytes, glucose, calcium, phosphorus, albumin, PTH, there and so forth. Many needs to be evaluated initially. Once we confirm that somebody has a kidney disease, further evaluation for serology like hepatitis B, C, or HIV or retroviral disease, anti-nuclear antibodies, rheumatoid factor, complements, then serum protein electrophoresis if there are any hemoglobin abnormalities, if you suspect there is any albumin globulin reversal. Then renal ultrasound is mandatory to measure the kidney size, check for any obstruction, hydronephrosis, stone, abnormalities of the urinary tract. And retinal examination is mandatory to look for any hereditary diseases or in case of diabetic kidney disease also. So this is how we estimate the GFR. GFR takes into consideration the age, sex, and body size also. The ethnic variability also is being taken in GFR equations. So, and proteinuria is mandatory to test for all sorts of kidney diseases. And even for risk stratification or for progression of kidney disease, proteinuria is very, very pertinent. Imaging, if you look at the imaging in kidney disease, we have plain radiograph looking at the kidney urinary bladder area, renal ultrasound, renal Doppler, which looks at the arteries and veins, and isotope renal scanning, which looks at giving us details on what is the function of right kidney, left kidney separately. Then computer tomography to delineate any structural abnormalities for recipient evaluation and donor evaluation. CT scan is mandatory. MR angiography, MRI scan of kidneys, very specific indications are there. Whenever it is required, we do it. Renal angiography, especially for the donors to evaluate how the arteries and veins are, we do the renal angiography. Retrograde ureterography for any bladder abnormalities are there, or ureteric abnormalities are there, any tract abnormalities, we do this retrograde urography. So these are the various imaging techniques. And to tell you all, these all techniques are available at one roof in our care hospital center. We have at one go, we have a state of art imaging technologies available, which covers all the available scans across the world. So all these modalities are there in our center. Renal biopsy is performed whenever indicated, whenever we suggest that the kidney disease which is there is not very clear, or somebody suffering from glomerular nephritis, then we will do a kidney biopsy. If you look at that, that's an ultrasound probe. There is a kidney. A small needle is inserted into the lower pole of the kidney, and that piece is taken, and this is called as kidney biopsy. Kidney biopsy is done at the early stages of kidney disease when it is feasible. There are no cysts, and coagulation profile is normal. Platelets are normal. Then we perform a kidney biopsy to understand what kind of a kidney disease this patient is suffering from. This facility and the reporting facilities, including light microscopy, immunofluorescence microscopy, is available at our center, with various trainings are also being done at our center. So therapeutic interventions are important at every stage of CKD, because from normal, if you screen them, then there is increased risk, then increased risk to damage, then there will be a decreased GFR. Once the decreased GFR starts, ultimately kidney failure will happen. Why we all have to treat kidney failure? Untreated, this will lead to death. So that's very, very important to treat CKD. So what are the key steps in medical care? So key steps are delaying or halting the progress. Some we have detected that there is a CKD. So what is important is to delay the progression or halting of the CKD. Once it progresses, then timely planning for long-term renal replacement therapy, like making a fistula and taking them for dialysis, or if they have a suitable donor, going ahead with transplantation. If there's a young child, so better to go for transplantation rather than medical management. So these are very, very pertinent. So if they have any pathological condition like glomerular diseases and all, they can be treated accordingly with medical management. So these are very key steps in management of kidney disease. So in the medical management, adequate BP control, adequate sugar control, adequate control of lipids if there are any lipid abnormalities, and avoidance of nephrotoxin like red meat, very high protein diet, and smoking cessation, alcohol cessation are all helpful in delaying the progression of kidney disease. If treating the somebody already has developed anemia, bone disease, and all, if somebody has developed acidosis and all, so they have to be treated accordingly with the medical management. Somebody has high phosphate, high potassium, and all, so they have to be medically managed accordingly. Timely planning for long-term replacement therapy during the progression of CKD. We need to educate them regarding disease progression, options of different treatment modalities like hemodialysis, peritoneal dialysis, kidney transplantation, and timely placement of access or AV access creation, and timely referral for renal transplant. If he is a suitable candidate for kidney transplantation, timely referral has to be done to the transplant center. So these are very, very crucial for management of kidney disease. If there is a young children, because there is a catch-up growth. If transplantation is delayed in them, their growth is hampered, and overall their life will be jeopardized. So children, we have to preempt and do a preemptive transplantation very early in the course of their CKD stage 4 itself. We need to plan for renal transplantation. So management of hypertension goal should be with the diabetes, goal should be less than 130 or 80. If they don't have a diabetes, we should target to try to bring it down to 140 over 90. So controlling blood pressure is most important to prevent the progression of CKD. Again, control of sugars are also very, very important to control the progression of chronic kidney disease. Nutritional management is very, very important. Most of the time, many people CKD or CKD develops means they go on to very, very strict control of dietary restriction. Most of them become malnourished at the end of the day. So we usually restrict them with a low protein diet, low potassium diet, low sodium diet, and other things can be taken. And water in moderation depends upon the person's urine output. So it is individualized. How much water to be given is individualized. Each patient we suggest according to their urine output, weight management, and all. We suggest urine output usually roughly will be around 1 to 1.5 liters per day. So there are various biomedical parameters are also there which we look into in managing these kidney disease patients in end stage renal disease to maintain their protein in their body, not to allow them to lose their muscle mass. So what are the indications for dialysis? When we say end-stage disease or dialysis, so if somebody has severe acidosis, hyperkalemia, patient has developed some heart problem, encephalopathy, high volume, patient has swollen up a lot, malnutrition is there, peripheral neuropathy, gastric symptoms like intractable nausea, vomiting, person is not eating well, or GFR is less than 10, these are the absolute indications for renal replacement therapy. So preparing the patient for dialysis, we need to counsel them, educate them that the options of dialysis, peritoneal dialysis, hemodialysis are there, immunization to be followed, prepare them for dialysis vascular access. If they have not made a AV access, arteriovenous access or a graft, then go for permanent catheter. And timely dialysis will help longevity of the patient. So summarizing the whole thing, CKD is a worldwide health problem. It's a global pandemic in which there is loss of kidney function over time. Patients with CKD generally progress to ESRD. Patients with CKD stage 1 to 3 are generally asymptomatic, whereas they develop endocrine abnormalities like we discussed, erythropoietin, bone, anemia, issues will ensue during the progression of CKD. An early diagnosis and treatment will help. And timely initiation of chronic renal replacement therapy is imperative to prevent the uremic complications of CKD that may lead to significant morbidity and death. So somebody who delays, I'm all right. If they delays with a very high creatinine, and that it leads to significant mortality and morbidity. So kidney transplantation improves the quality of life, improves the longevity, overall survival benefit. It gives in professional life to a person who is doing profession, employment for those youth, and they can lead a normal family life. And a transplant patient can have a parenthood, or parenting is possible post kidney transplantation. So overall, there are a lot of benefits with kidney transplantation. Many people feel that once end stage renal disease, they don't have an option. It's at the end of the road of their life. It's not true. So lot of benefits with kidney transplantation. And this is how a kidney transplantation is being done, and more details will be dealt in the next half an hour. So the donor kidney, which is cut from the left side, is given to the recipient. That is a transplanted kidney. So the recipient will have 3 kidneys in him. So the top ones are the diseased kidneys, which are left in situ. They will not be removed. And the transplanted kidney, which is placed on the right side of the abdomen, lower abdomen, and 3 kidneys will be there. The transplant patient will have 3 kidneys in him. So care hospitals at Banjara Hills, Hyderabad has state-of-art technology in terms of technology, equipment, the skill, the doctors, the teams that are available here, which is state-of-art. And it's a multi-organ transplant center. Heart, lungs, kidneys are routinely done. It's a center of excellence for kidney transplantation with an excellent lead surgeon, Dr. Parsad Raju, with us, and a dedicated urology and anesthesia team. And there are good overall patient outcomes. Ultimately, the outcomes matter. So we have a good overall patient outcomes at our center. So this is what we have. And thank you for your patient hearing. Thank you very much.
Thank you, Dr. Reddy.
Hello, am I audible?
Yes, sir, you are.
Hello.
Yes, we can hear you.
Yeah. Uh, Good afternoon, Nigeria. I think your people are 4.5 hours behind, so it must be around 12:30 or 1 o'clock in the afternoon, I guess. At the outset, I would like to tell you that I have been acquainted with Nigeria because I have a very good friend who's a urologist. His name is Dr. Dayo. He is a consultant urologist at Lagos, and he practices there. So good to reconnect with you people, and wish to continue our association in future. Well, ladies and gentlemen, I am Dr. Prasad Raju. I am a consultant urologist and a transplant surgeon at Care Hospital, Banjara Hills. We have a group of 5 urologists in this center who are capable of doing transplants too. And we are ably supported by Dr. Vikranth Reddy and his team, a senior person in our center, and supported by a dedicated anesthesiology team from the Axon team of anesthesiologists. And we have a group of dedicated nurses, theater staff, and post-transplant unit nursing staff too. What every patient needs to know about transplantation. Briefly to run through or review of what Dr. Vikranth Reddy has told us, how do the patients present to us? Generally, they present with swelling of both feet, edema of the face, and they gain weight. And they come with abdominal distension because of ascites. They have difficulty in breathing because they accumulate fluid in their lungs, and they have loss of appetite and confusion because of uremia. And there are 2 types of kidney failures. That is, one is acute renal failure and a chronic renal failure. Briefly, the causes of acute renal failure are low blood pressure, due to dehydration and other causes. Blockage of urinary tract, it could be due to stones and other causes. Muscle breakdown, and another condition called as hemolytic uremic syndromes. And causes for chronic kidney diseases are diabetes mellitus, which is quite prominent in the world now and increasing in numbers, high blood pressure, nephrotic syndrome, polycystic kidney disease, etc. So once a patient reaches end-stage renal disease, that is, as Dr. Vikranth Reddy had mentioned, if their GFR is below 15 ml per minute, they reach end-stage renal disease, that is stage 4, stage 5 chronic kidney disease. They'll require some kind of a renal replacement therapy. So first thing will be, they will be started on dialysis. The different dialysis are hemodialysis, peritoneal dialysis, and continuous ambulatory peritoneal dialysis. And they can opt for transplantation. Renal transplantation can be living-related transplantation, living unrelated transplant, paid transplant, that is the swap transplant, which we have done one in our center. ABO incompatible transplants, we have done 2 or 3 here in the center. And disease donor transplant, that is, we take the kidney from the brain dead, or generally called as cadaver kidney transplantation. And proceeding with kidney transplantation is voluntary. Kidney transplantation is a technique of implanting a kidney from one person to another who has end-stage renal disease. Kidney transplantation is the ultimate treatment of choice for patients with end-stage renal disease, as it offers better long-term survival and quality of life compared to dialysis. So this is a graph showing the numbers of living and disease donor kidney transplants by World Health Organization region as reported by the Global Observatory. This is from 2015 study. So as you can see, the blue color depicts the living donor transplantation, and the brown or the orange color depicts the diseased donor transplantation. And the highest number are done in North America, and the number of diseased donor transplantations are more compared to living donor transplantations in North America. Next comes the Eastern Mediterranean region. Even here, the diseased donor transplantation more compared to the living donor transplantation. And in Southeast Asia and in India, we have more of living donor transplantations than diseased donor. But for the past 5 years, this particular number have increased, and of late, we are doing quite a bit number of diseased donor transplantation. And coming to Africa, the numbers are very low, and most of them are living donor transplantations, and negligible number in diseased donor transplantation. What are the indications for transplantation? The medical indications are generally glomerular diseases, diabetes, polycystic kidney disease, hypertensive nephrosclerosis, renovascular and other vascular diseases, congenital, rare familial and metabolic disorders, tubular and interstitial diseases, and a retransplant if a previous transplant fails, or if there is a graft failure. There are some contraindications. We divide them into absolute contraindications for receiving a kidney transplant and a relative contraindication. The absolute contraindications for receiving a kidney transplant are non-compliance, non-adherence with prescribed medical therapy, including dialysis and medication, unstable cardiac disease, severe pulmonary disease, including untreated pulmonary hypertension or uncontrolled pulmonary hypertension. Smoking, if the patient refuses to quit smoking, then generally we do not offer transplant to them. And acute active abuse of drugs, alcohol or other substances, severe vascular diseases, active infections, age greater than 80 years, and recent diagnosis or ongoing treatment for cancers. If somebody has cancer and they require transplantation, we wait for 2 years. They have to be cancer-free for 2 years for low-grade malignancies, and they have to be disease-free, that is cancer-free, for 5 years for high-grade malignancies. And the exception are non-melanoma skin cancers. And the other condition which we avoid are uncontrolled psychiatric disorders. And coming to the relative contraindication for offering a kidney transplant is acute or chronic liver disease, obesity, that is the BMI of more than 35, age with associated comorbidities, financial concerns, untreated or inadequate treatment for mental illness, and history of cancer, as I mentioned earlier, and inadequate social support back home. So what are the criteria for diseased or a cadaver donor selection? That is, if we take the kidney from a brain dead person, that is, the brain dead person should have irreversible brain damage, and they should have a normal renal function appropriate for age. There should be no evidence of pre-existing renal disease and no evidence of transmissible diseases, and they should be ABO blood group compatible, and there should be a negative cross match to prevent rejection, and best HLA match possible will be selected. There will be a battery of tests done once the donor and recipient are selected, and donor and recipient are evaluated separately. From the donor side, routine tests are done, except for a few special tests like a CT angiogram to see what the number of vessels are and the quality of the kidney. And we do an isotope renogram to see the differential function of both the kidneys. And we do a HLA match of both the recipient and the donor. And the recipient requires more number of battery of tests, like the blood work, blood counts, kidney functions, liver functions, viral markers, and additional infectious studies. And urine for 24-hour urinary protein, urine culture, and urine analysis. And all the required vaccines should be taken by the recipient. Generally, we take consultations from all the other specialties to get fitness for surgery. Most of the time, colonoscopy and upper GI endoscopy is done. Mammography and pap smear for female recipients. Prostate examination and evaluation for elderly male recipients. Cardiac testing, specific testing related to individual medical history, and dental clearance. So, coming to international patients, there are a few requirements, like we need to have an authentication of recipient and donor relationship by their respective embassy. And here we have a state committee and local body approval for transplant is required. And the recipient and donor need to get a visa for adequate number of days of stay in this country from the Indian embassy. So once the donor and recipient are evaluated, and once they're ready for surgery, what do we expect on the day of surgery? The in living related transplant, what is the schedule like? So we admit both the patients 1 day prior to the day of surgery, and recipient will undergo dialysis in the evening. IV fluids are started for the donor, and labs are drawn for both, and proper consents are signed. And the next day, first thing in the morning, we prefer to start the transplant at 7 or 8 o'clock in the morning, and we proceed to the OT. Coming to the surgical procedure overview, the transplantation is done, the incision is taken in the right side of the abdomen, in the lower part on the right side, preferably on the right side. Left side also can be done, but technically the right side is easy. Left side is taken only for if we have to do a second transplant. So we take a curvilinear incision, and both the recipient and donor are taken in at the same time, and two teams work on both the recipient and and the donor separately. And the donor nephrectomy is done, and the kidney is taken en bloc. What does the en bloc kidney donor kidney contain? It has the kidney, it has the artery which supplies blood to the kidney, and the blue one is the vein which drains blood from the kidney to the heart, and the urine tube which is called as a ureter in medical terms. So the kidney is taken out, and it is perfused with ice cold solution, and it is kept in ice. And then it is transported to the recipient theater, and then we proceed with the transplantation. And the kidney is placed in the right iliac fossa, the right side of the lower abdomen. First, the vein, that is the blue one, is attached, or we call it as anastomosis, to the recipient recipient vein, and donor renal artery which is the red one, is stitched to the recipient external iliac artery, and the urine tube is anastomosed or attached to stitched to the urinary bladder. So 3 areas we do the stitching. It's called as anastomosis. And this is a animated picture of renal transplant, which I'm going to play. So these are different types of incision. The skin is incised, and there are different layers of subcutaneous fat, muscles, 3 layers of muscles. They are opened. The intestines and their contents are pushed medially, and external blood vessels are exposed. The kidney is placed in this region. The perfused kidney is taken, kept in the right iliac fossa, and first the vein, the blue one, is donor vein. Renal vein is attached to the recipient external iliac vein. And this is how we do. This is the blood clots or whatever is there is removed, and this is how we stitch the vein to the recipient vein. And next, the artery is taken, the red one, the donor artery is stitched to the external iliac artery of the recipient. And it is clamped, and once the clamps are released, blood flow goes into the kidney, and kidney becomes pink and firm, and most of the time urine is seen on the table. So the urine tube is spatulated, is brought onto the urinary bladder of the recipient. The urinary bladder is opened, and the urine tube is stitched to the urinary bladder of the recipient with the stent in situ. And then the urine will produce into the bladder, and it comes into the urine tube. The bladder, the different layers of the abdomen are closed in layers, and the recipient has a tube drain and a urine tube. Generally, the procedure lasts for 3 to 4 hours, 2.5 hours for the donor, and 3 to 4 hours for the recipient. And after anastomosis and after release of clamp, 98% of the time urine is produced on the table, and then we go ahead with anastomosis of the ureter onto the bladder. We keep both the patients in the recovery room for 1 to 2 hours, surgical intensive care unit overnight for closed observation, and we transfer to the room from the intensive care on the second postoperative day for the donor, and on the third or the fourth postoperative day for the recipient. And this is how our recovery unit, that is kidney transplant unit, looks. And this is the transplant we did recently, 3 days back, and both the patients are from Congo, and son donated to father, and both are doing well. And his renal functions came to normal on the second postoperative day, and hopefully we are planning to discharge him, both of them, in another 2 or 3 days. What are the risks related to transplantation? So there are inherent medical and surgical risks with surgeries, with any kind of surgeries or any invasive procedures. We have divided them into the minor and major surgical complications. Most complications are minor and they improve over time. What are they? They are postoperative nausea or vomiting. They can have constipation. They can have ileus. It might take 2 or 3 days for them to open up the bowel, and there can be wound infections. These are minor complications. Some complications are more serious and may require additional surgery or procedure postoperatively. There could be a blood or clot in the artery. It could be a urine leak from the urinary anastomosis, and they could develop hernia at a later stage from the operated wound. And some people may develop deep vein thrombosis or pulmonary embolism due to clotting of blood in the veins. But necessary precautions are taken to prevent these complications. So what are the risks? Again, in detail, we divide them into vascular complications and urinary complications. Vascular complications, they can have bleeding from the anastomotic site postoperatively, or can develop blood clots. Percentage is 2 to 5% they can have these kind of complications. That's vascular complications. And generally they happen from between the first day and the 10th postoperative day. And if these happen, we might have to have a re-exploration, go in back into the theater, reopen and re-explore and rectify that issue. And coming to urethral complications, the percentage is 7 to 10%. That is, it could be a leak from the urinary anastomosis or narrowing of the urinary tube. Generally, it occurs from the 10th day, between the 10th day or 6 months post-transplant. Even this, if it happens, they might require re-exploration and they might require replumbing work into the bladder. There could be risks of infection. Risk increases after surgery because most of them are on immunosuppression, and they could have risk of rejection. And that's why we give importance for compliance. They have to take medicines properly and on time, as advised. And risk of developing cancer. This is because of immunosuppressive drugs, and a small indolent cancer might flare up because of immunosuppression. And they may develop skin cancers, which is quite common in Western countries. And female recipients of childbearing age are not recommended to become pregnant on immunosuppression until unless they discuss it with the physician first, so that they modify the medications, the immunosuppressive medication. Psychological risks, they can develop depression, post-operative psychosis, post-traumatic stress, anxiety, and feeling of guilt. So once you had transplant, what is the follow-up? Generally, we see the recipient 3 days in a week for 3 to 4 weeks. The sutures and the clips are removed on the 7th or 10th post-operative day for the donor, and on the 14th day for the recipient. And that small tube which we put in the tube, that's called as a double J stent, is removed after 2 to 3 weeks. And there is a possibility of kidney biopsy if there is a suspected rejection in the recipient. So looking at comparison of living and deceased donors. So average survival for a living donor is around 15 years, but the percentage is less if as the number of survival years go. So we have seen people who have survived for 20 years or 25 years on this thing, but the numbers are less. And for the disease, the survival of the graft is 10 years. Kidney function is usually immediate in living donors, and it can be delayed in diseased donor transplant. Surgery date, it is scheduled for living related transplant, and it is an emergency or unknown timing for disease. Waiting time is shorter for living and typically longer because they have to be in the waiting list for a disease transplant donor. And medications, dose may be lower in living related transplants. When is transplant deferred? When there's infection, cancer, high chance of morbidity or mortality with surgery, anatomical body structure problems. If the BMI, as I told you earlier, 35, but if it's more than 5, it's an absolute contraindication, because technically it will be very difficult to place the kidney in the abdomen if the BMI is more than 40. Inadequate post-transplant plan, and active abuse of drugs or alcohol, and untreated or inadequately treated mental illness, and as I told earlier, medical non-compliance. What are the risks of kidney transplantation? With medication, because they have to take long-term medication, they may have side effects, and the medications are expensive. They may develop infections because of immunosuppression. Rejection, chronic rejection can happen due to immunosuppression. They can develop cancers. Coronary artery diseases, they may develop fresh coronary artery diseases, and fresh diabetes can happen with steroids, and surgical complications, as I mentioned. There could be financial concerns. And what are the benefits of kidney transplant? Better quality of life. Quantity of life is longevity of life. It's more like your own kidney than dialysis. It's not time consuming, because for dialysis, you have to take an appointment and spend 2 to 3 hours in the dialysis unit. And with transplant, you have more freedom to travel, fewer dietary and fluid restrictions, return to work or school. And in children, it's very beneficial because they'll have normal growth after transplantation. And fertility also will improve after transplantation. Lifestyle after transplantation, they should follow a good diet, They should maintain a healthy weight, exercise regularly, monitor blood pressure, cholesterol should be under control, and no smoking strictly, because there's a very high chance of developing infections, lung infections, if they continue to smoke. Health maintenance examinations regularly, infection prevention, avoid crowded areas, and immunizations should be taken as prescribed by the doctor, and avoid pets. Potential outcomes: kidney works immediately in 70 to 80% of the patients. Slow or delayed kidney function, that is called as acute tubular necrosis, as mentioned earlier. They may require dialysis till the kidney opens up. Sometimes it might take a few days or a few weeks, and that is 20 to 30%. And very rarely, I would say it's not 1%, it's 0.1%. On table, some people may have hyperacute rejection, that is, it fails immediately on the table, and there's no treatment for hyperacute rejection. And hyperacute rejection we rarely seen, and in our center we have not seen as yet. And why do transplants stop working? As I mentioned, non-compliance with medical treatment, and if the patient develop infections, we need to decrease or stop anti-rejection medication because of other health issues. Generally, they slowly over a period of time they develop chronic rejection and changes in the kidney over time, and some of the native kidney diseases can come back in the transplanted kidney, and as I told you, rarely surgical complications. Rejection can be seen at any time. Often they don't have symptoms, so self-monitoring is essential. Labs should be done regularly, weight should be maintained, blood pressure should be maintained, and temperature should be checked. And treatment available may require admission to the hospital, a biopsy is done, and IV medicines are given. They may change immunosuppressive medication to control infections, and sometimes rejection may lead to loss of transplant kidney. Post-transplant commitment: daily self-monitoring of blood pressure, weight, temperature, blood sugar, medication take exactly as prescribed, regular clinical visits for life, labs done regularly, and biopsies when required, and there should be a regular communication, and you have to share your concerns and be part of our team, not the surgical team, but the nephrology team. So this is a caption for to encourage organ donation. That is, when you give yourself, you receive more than you give. Thank you. Any questions from the audience will be answered by both either me or Dr. Vikranth Reddy.
Yes, there are a few questions. I'm waiting for Pankaj to start and take the questions.
Hi, Doctor. Thanks a lot for the presentation. I have received a couple of questions. The first question is from Martha. She's from Nigeria. She says, I have a issue with my hip bones. The pains are unbearable. Hence, I have to take painkillers almost every day. My age is 23. Can this harm my kidneys?
Yeah. Yes, if you are taking painkillers other than paracetamol or tramadol every day, they definitely will damage your kidneys. So you have to be careful. Why don't you fix the problem with the orthopedician rather than taking painkillers? So physiotherapy, then orthopedic consultation or something like that. So that would help you relieve your problem. And only paracetamol and tramadol are advised. None other than these. Anything else other than these will cause kidney damage.
Okay. Thank you. Then there is another question. This is from John. Mr. John is again from Nigeria. He has a very different kind of a thing. He says, my son is a health freak. He consumes heavy doses of protein shakes every day, and also the meal is less of carb and more of proteins. Is this healthy in long run?
Yeah, very high protein every day is also not advisable. We have seen some people who are bodybuilders and they take creatinine powders and all. We have seen that, and that also damages the kidneys. So anything in excess is not good. And always the principle of moderation is better. So better not to have a very high protein every day. Whey protein in moderation is okay.
Protein is
With
okay in
is
moderation.
okay. In moderation is okay. Yeah.
Okay. Then the third question comes from Kenya. Does not want to reveal his name. He is 32 years old, unmarried, and he says, my kidneys have failed. The doctors here have already started with a dialysis plan. We do it twice a week. It makes me feel weak. I'm unable to work. The medical tours team, that is our team. So the medical tours team recommended a transplant for me, but I do not have enough money for it now. How long can I sustain with the help of dialysis?
So nowadays, with good dialysis technology available across the world, so dialysis lifespan is about 10 to 15 years. But the question is, if somebody is on dialysis, they are incurring lot of expenditure on dialysis because they have to buy medicines, dialysis cost every day going to the hospital. It hampers the quality of life. Everything is not that good for dialysis. But whereas transplantation, like they have good quality of life, their cost also comes down except for the medicines. But whereas if they are on dialysis, they have to spend on medicines every day. Rather, they can spend on medicines after transplantation. So that way, I would feel that it's not a correct economical proposition to stay on dialysis.
Okay, okay. All right. And the same patient actually had another thing as well. This was actually interesting. So when me and a doctor were doing, a doctor from our team, we were doing a call with this patient, and the doctor recommended a transplant for him. And then he told him that, it's not really good for you. You are already feeling so weak after dialysis, and you are unmarried. So if you really want to get a healthy life back, you should go for transplant. And all of a sudden, this person, he showed us a liquid, which is a kind of a syrup, which is supposedly from India. And his local physician has highly recommended this syrup from India, Ayurvedic syrup. And I think we call it as kadha. So, see, this Ayurvedic syrup, doctor recommended him and told him that, you can revive your kidney health within couple of months. So, should patient really be relying on such kind of information?
No, not at all. Those are all false information available. So this many of these people who just proclaim that they claim that this works, that were usually none works. So once the GFR falls to less than 15, it's if it is a chronic kidney disease, that's irreversible. It will never reverse. So they should not rely on these kind of things. There are many things available. Some people talk about Neary KFT is there, things like that. There are a lot of syrups available. There are a lot of treatments available in India also, in many places like Haridwar and somewhere in North India, South India, Kerala. So everywhere in many places there are many people who claim that we cure the kidney disease. There is no need for dialysis or transplantation, which as a scientific body or as a scientific evidence, there is nothing like that. So I would strongly say no for all these things.
Okay, all right. Now, the fourth question is from Nigeria. This gentleman says, Mr. Mishra, he says, I have been advised transplant, but I don't have a close family member who can donate a kidney. What do I do in this case? And doctor, we keep on getting such kind of requests often. So what should be the best answer for this, according to you?
There are different options. Like as I told you, if your center has a cadaver transplant program, I think that program should be encouraged there in Nigeria and in other countries of Africa, because quite a lot of people they don't have donors, so they'll be left on the lurch. So that program should be encouraged there. And for him, the other solution is any other donor other than his relative. ABO incompatible transplant can be done. That is, if even the blood group doesn't match in their family members, we can do an ABO incompatible transplantation.
Okay, but that will increase the cost, right, for the compatibility?
Yes, because they need to be given a better immunosuppression. They have to be in the hospital here for certain procedures before transplantation.
Okay.
The other thing is if a swap transplant is another option, like two recipients who do not have relatives, but if they have somebody with another group, you can swap the kidneys like with the same group. I think you understood what have been telling.
No, can you please elaborate that?
So actually, the thing is suppose two families are there. Suppose the recipient is A group and the donor is B group. Okay.
Okay.
So we can do across this group what sir was mentioning is ABO incompatible transplant. That is one type of transplant. The other one sir was mentioning was swap transplant. In swap transplant, the thing is two families are there but different blood groups. One other family can donor can donate to a different recipient, and this donor can donate to that recipient. So swapping of the kidneys.
And is this
So
allowed in
cost
India?
comes down. Cost comes down here.
Is this allowed in India?
Yeah, it's allowed. It's allowed. It's legal in India. It's allowed in India. Swap transplant.
Swap
Yeah,
transplant is allowed in India.
allowed in India. Yeah. So ABO, as we just discussed, it would be costly affair, but whereas swap is like any other regular transplant, but two transplants have to undergo simultaneously.
So 4 surgeries at a time. So it has logistical issues and other things, because we should have 4 teams working at the same time.
Okay.
So, but we do it at our center. As I told you, we have got all the technologies, all the expertise available. So, we routinely do ABO, and we also do swap. We have done swap in before. We have done ABO incompatible transplants before. So, we are geared up for all such modalities of treatment at care hospitals.
Wonderful. Okay, then I have some more questions. I hope you are not tired.
Go ahead.
Okay. The question is from Hoodoo. He is attending the session now. How is it being? Sorry, my question is how is it being removed? The structures in the lower parts of the body after surgery. I don't know if I understand this. Uh,
Is he mentioning the donor or the recipient side?
he is mentioning the recipient side, I guess. Sorry, donor side.
Yeah, donor side, we can do either open surgery or laparoscopically, we can remove the kidneys.
Is it possible even laparoscopically?
Sorry?
It is possible even laparoscopically.
Yeah, laparoscopic donor nephrectomies are done.
Okay, all right. Then another question is from Sakinath Buba Medugu. I'm from Nigeria. Have a question about my mom's condition. She was diagnosed with CKD, but not on the dialysis. She always complains of joint pains and bilateral loin pain, and her PCV is always low despite on iron, sucrose together with high BP. I am a nephrology nurse and a critical care nurse. How well can we improve to her health, doctor? Thanks.
Yeah, so basically, as we discussed, CKD will cause anemia and bone issues. So, as it's a chronic disease, there is no wonder drug or wonder treatment for this. So, they have to be on erythropoietin supplementation, iron supplementation, multivitamin supplementation. Then only things would improve, and it takes a longer time for them to cope up with the illness. Yeah.
Okay. Then one of the last questions from the guest, again, Hoodoo. My other question is, my aunt is diabetic and she have hypertension and tumor in right kidney. How she can prevent for kidney failure?
No, first, basically, if it is a tumor, most probably it is a malignant growth. That kidney has to be removed first. So to
Okay.
prevent spread of the cancer, whatever it is. So
Okay.
we have to evaluate and find out whether it is a benign tumor or a malignant tumor.
Mm-hmm.
And then if it is a malignant tumor, that kidney has to be removed with the tumor. It's called as radical nephrectomy.
Okay.
And if I understand, her renal functions are normal or she's in renal failure.
That is not mentioned here. Hudo, would you be able to give more details on your aunt? Yes, he's just saying yes. He's typing the message. In the meanwhile, Hudo, please give more details about your aunt, please. We are waiting for your message. And can this surgery be done in India, doctor?
Yes,
Removal of the
yes.
kidneys.
Yes,
Yes.
it would need evaluation. We'll evaluate the scans and differential function, and accordingly, if the patient is fit enough, we can go ahead and do the transplantation. We can go ahead and do the surgery, removal of that tumor.
Okay, okay, all right.
I guess her other kidney is normal and she's not in renal failure. Then a regular radical nephrectomy, that is removal of the whatever tumored kidney, can be removed. It can be done laparoscopically also or open surgery.
And this surgery can be done at care hospitals, right?
Yes,
Yes,
yes.
yes, it can be.
Okay, okay. One of the last questions I have is, one sec. I'm a 39-year-old mother of three children. The sides of my waist always in pain. What could be the reason?
So that needs to be evaluated. Basically, an ultrasound abdomen should be done. Usually, kidneys will not cause any pain if there is a kidney failure. Only kidney stones or any infection which cause swelling of the kidneys or any obstruction and all will cause pain. Usually, ultrasound abdomen, if we do, we'll come to know whether there's internally any problem is there. So most of the time, these pains are external or backbone related, muscle pulls kind of thing.
Okay, all right. And another one from Orubor Philip. Philip says, I'm from Nigeria. I would want to ask if any damage would be done if the damaged kidneys were to be removed.
No, most of the time in renal failures, the kidneys become shrunken and they're very small. They do not cause any problem until unless there are indications like as I told you, if they cause problems with if the size is very big, if the kidney is infected, or if the native kidneys are producing excreting too much of protein, then only we remove the native kidneys. Otherwise, we don't do anything for that. They just become small and shrunken. That's all. Or sometimes these small kidneys can cause hypertension because of narrowing of blood vessels. And if these things happen, we generally do a native kidney nephrectomy. Otherwise, generally we leave them alone.
Okay, all right. So
But
what I
really,
will
if he
do
wants
is,
it to be removed, we can do it, but it's not indicated.
okay, okay. So what we can do is, like, we can ask these patients or their relatives to send us more details or the medical reports, and we can send it across to you, so that you can review it and give a detailed opinion on that, right?
Yes, that can be done.
That can be done. Okay. Sakinat had just who was talking about her mother. So she had just added to it that for the high BP not responding to CCB and diuretics, can we add any other antihypertensives, doctor? And for the urea, any drug of choice to reduce that level?
Yeah, usually CKD is a very difficult to treat hypertension. So they would usually require 2 to 3 drugs. So you said CCB, diuretic. We can add on a beta blocker. We can add on a beta blocker like metoprolol, or alpha beta blockers like carvedilol can be added. And apart from that, we can add alpha blockers like prazosin or anything like that. And then we can add even centrally acting drugs like clonidine. So second choice would be beta blockers, then carvedilol, then you can add on alpha blockers like prazosin, then you can add on centrally acting drugs like clonidine. So with that, I think it should help, and it should improve. So that's one. Then there are not many drugs for reducing the urea levels, but we call something like enteric dialysis. Enteric dialysis, we can use pre-probiotics, like commonly available pre-probiotics. We can use them for control of urea. So pre-probiotics can be tried.
Okay, okay. Dr. Abdullahi, can you please unmute yourself? You have some interesting question. Sorry, Dr. Abdullahi is from Somalia. Please unmute yourself. He has a question. Uh, would like to ask what is the
Most
most common
common most
cause
common cause for nephrectomy
nephrectomy
patient.
patient die after done?
So that's what I didn't understand, that what is die after done.
Is it a common cause of a death after nephrectomy or something? Or is it assumed to be a common cause? Dr. Abdullahi, if you can hear us, please unmute yourself and ask your question, please.
Or can he reframe the question again?
Yes.
It's better that he reframe the
My
question again.
question is,
Okay, here he is. Yes.
hello,
Yes, yes,
hello.
doctor. Please continue. Please continue. We are listening to you.
My question is, what's the most common cause the patients who's proceeded nephrectomy? Why they die? What the most common cause lead to die after nephrectomy?
Most common cause of death after nephrectomy.
Yeah.
Yeah, most common cause would
Or
be
complication? Or complication?
a complication. Maybe if it is immediate post-op surgical site, in the sense like if there are any leakages, any bleeding, hemorrhage is the common immediately after nephrectomy. Otherwise, if there are any infections, sepsis is the one other cause. Immediate cause, surgical causes within 12 hours or 24 hours would be any bleeding or hemorrhage or suture leak from that side. Or if it is beyond that, then most commonly it is sepsis. Infection is the most common cause.
Okay. Dr. Abdullahi, are you satisfied with the answer? Do you want to ask more questions? Okay.
Okay, it's right. Okay.
Okay. I think he's done. Okay. So, doctor, I think that's all. I mean, we have asked you all the questions from the people. And besides that, if at all anyone wants to ask any questions later, they can send it to us, or they can send it to us on email. I will just type the email over here. Our email ID is hello@medicaltours.care. Okay. Or you can send it to us on WhatsApp. You have received the WhatsApp messages from us since morning. So you can send us your queries on WhatsApp. And okay, there is one more question. My name is Dr. Barkhat from Somalia. My question is, dialysis are two hemodialysis and peritoneal dialysis. Which one has the better outcome?
So it's hemodialysis versus peritoneal dialysis. Both are similar. and both have similar outcomes, even short-term or long-term outcomes. Both are similar. Various studies have also shown that hemodialysis and peritoneal dialysis are equivalent, and both have similar outcomes. Compared to these two, transplantation definitely has better outcomes as compared to these two. So that's
Okay. All right. Mr. Hudu, I suggest please unmute yourself, ask your question directly to the doctor. He's saying, is the patient, sorry, does the patient need another surgery to remove the structure?
No, it is generally done as an outpatient. No, it's generally done as an outpatient. The sutures are superficial. We don't remove the inner sutures. Only the skin sutures are removed, not the inner sutures. And for the removal of the stent, we just do a small endoscopic procedure. We pass a scope into the bladder, catch the stent, and then remove it. That is removal of the stent after 2 to 3 weeks. These are both are simple procedures.
Okay, noted. I think we are.
Pankaj,
I think we are done with it. Hello.
Pankaj, there's another question on the chat, on Teams chat with the group from Mohammed. Can you look at it?
mega urated.
We already answered that question, Dr. Barkhat, right? My name
Right.
is Dr. Barkhat. Yeah, we already asked that question. Hemodialysis and peritoneal dialysis.
Got it. Thank you.
Yes, yes, yes. So I think we are done with all the questions. And doctor, thanks a lot for patiently answering all these questions. We are receiving a lot of appreciations for your presentations. Thanks for your time. And if at all you want to say some final words before we ending the session.
Yeah, thank you everyone, whoever is present for their patient hearing. So if they have any queries or anything like that, they can forward to you guys, and you can coordinate with Inderjit here, and we can do the needful. And to be in brief, we have all the expertise here. So we have excellent surgical teams, medical teams, anesthesia teams, and almost all the surgeries are being performed at this center. So they can be rest assured that everything is done under one roof, and we can give the best of the best services here. Okay. So,
Wonderful. Care Hospitals in Hyderabad, India is one of the best hospitals on our panel. The team is very proactive. We've been dealing with them for more than a year now, and we got amazing results with them. Okay, so whoever is looking for looking for a treatment on the kidneys, or it's a basically multi-specialty hospital, so people who are looking for such kind of treatments can get in touch with us, and we will connect them to care hospitals directly. Okay. Thanks a lot, all of you, for patiently being with us. It's more than an hour, and we can understand how interesting this presentation must have been, because people are like, here, like I see 31 people still being around and attending the session. Thank you. Thanks a lot, everyone. And thank you, doctors, for your time and answering all these questions. We really appreciate that. Thanks a lot.
Thank you.
thank you.
Thank you, Dr. Reddy. Thank you,
Yes. Have a
Dr. Raju.
great day. Thank you. Thanks, Anuj.
Bye now.
Bye, everyone. Thank you very much for your cooperation. Thank you.
Thank you.